Hello, everyone. Happy Friday. Nice to see you all. I'm sorry for the background noise, but we will make do. Uh, Profez is on his way. And today, just like yesterday, is an all internal CP Solve affair. We have VJ who is scribing and Jimena who's doing teaching points. And then we have a mark case, which is a like a hyphenated word that I think all of you probably have feelings about and know exactly what I mean. But it seems like we're getting a different version of a mark case. So when we hyphen this up, Mark, why don't I give the mic to say hello? Maybe reintroduce yourself to the small number of people who are maybe joining noon, and we'll kick it off shortly thereafter.
Yeah, absolutely. Yeah, my name is Mark. I'm one of the CP Solvers team members. I'm a third year internal medicine resident at UPenn in my last month of residency, which I'm really excited to move out to the Bay soon in a month. And yeah, I have a really fun case. I'm on nights right now, and I have a really nice case from last week. A little bit of a twist. I'll explain a little bit why at the end, but excited to present it.
See, Prof. Rez is here. Thank you, Mark. Prof. Rez, good morning.
Good morning. How's it going? Where are you?
Prof. Rez, I'm in paradise, or as otherwise, or as like my mom would say, a shopping mall, which is her paradise. It's honestly, we've been on like an outdoor adventure in Boston. We've been by the river. We wanted to see so many cool things. We're headed to the airport in a couple hours, and her final wish this morning was to go to a mall called the Cambridge Galleria. It's more than just like her joy for like walking around and checking things out. It's because when she would come visit me when I was in Boston, when I was in like school and classes and whatnot, she would just come hang out here. So it's reliving many memories for her. It's a little bit interesting though, because COVID seems like COVID just devastated this mall, and it's like completely being revamped now. And so I think she was a little like sad to see that all the stores have closed down. But anyway, that's my classic long-winded answer to your very short and concise question, Prof.
Where is she now, Robbie? Which store is she checking out?
She started off with TJ Maxx. You know, she starts off by trying to find a bargain at TJ Maxx. Any recommendations, Prof.
Oh man, TJ, that's the place to be. She'll find a lot of good stuff there.
Yeah. We're headed for a nice lunch right after. But I'm glad I get to spend an hour with you, Mark, and VJ, Jimena, and everyone else who's here. What are you up to?
Not much. I'm still on the MOD rotation. So at 9:30, I'll have like a brief meeting, but I'll jump back in.
Yeah.
But otherwise, I brought my golf bag, which is in the corner here, because at 4:30 today, I'm going to the golf course on the VA.
Yes.
Gonna play some golf, and then I head to play soccer after that. And then tonight, Liz and I are doing Taco Bell for dinner, so looking forward to that.
Oh my gosh, I think you're gonna buy the whole restaurant at the end of golf and soccer.
By the way, I don't have my cell phone with me, just FYI. I forgot it at home today.
Oh, okay. No worries. Yeah, I was sending you love messages and got none in return, so I was a little, I was a little heartbroken. I was gonna say one more thing, but I completely lost my train of thought. I think, Prof. Rez, we should hear your wisdom. And I was gonna say, so y'all, since Prof. Rez has to duck out for 5 or 6 minutes, I think we started a tradition to do breakout rooms at that time, and I think it would be really cool to do that again today. So around the halfway mark when Mark's presenting, please collect your thoughts, and if you are down for it, please share them in the breakout room. So just know that we'll try to do that when Prof. Rez is done. All right, Mark, let's rock and roll.
Let's do it. All right. So our first aliquot. So we have a 61-year-old gentleman that comes in with 2 weeks. Sorry, I lost my screen real quick. One sec. Yeah, so a 61-year-old gentleman that comes in with 2 weeks of polyuria and polydipsia and 1 day of word finding difficulties and confusion.
This is a rocket of a start. Maybe I'll just share a few words and thoughts and then give the mic to Robbie to add to that. First of all, Mark, when do you start your gig officially?
So I have 1 month left of residency, and then I start August 1st. And we just
Stanford, yeah.
yeah, we just signed our apartment last week. We're so excited. I can't wait.
They're so lucky to have you. It's a great group out there.
You're very,
Congrats.
it's very kind. Thank you.
All right. So this is interesting because right away you have to ask the question, which was first, the polydipsia or the polyuria? Think about it. If I drink a lot of fluid, I'm going to pee a lot. It's very odd for that to be the case. Like if you're just applying base rate, it's almost always the polyuria that's prompting the polydipsia. And the moment, it's rare. So this is where I think a specific gravity and a history is really, really helpful. Because I think the problem we're going to be solving is a problem of polyuria. And so what is polyuria? It's when you're creating more than 3 liters or so of urine per day. I think it's 3. I don't remember the exact cutoff. But if you think of a small cup is about 250 cc's. We're encouraged to drink about 8 cups of water a day to prevent kidney stones, to keep that urine flowing. Once you get north of 3 liters of urine a day, you're in that category of polyuria. So when you're in that category of polyuria, the question is, what's driving it? What is the pathophysiologic mechanism for it? And if you're applying base rate, there's a few things you should think of right off the bat. And the first thing you should think about is glucose. And this is where a urinalysis would be so helpful, because it'll give you the specific gravity and it'll let you know if there's also glucose in the urine. Because when you are delivering so much glucose to that nephron, you're going to overcome the ability to hang on to the sugars and it'll show up in your urine. So hyperglycemia, that's like, I think the first test I would do on anyone that came in with the report of polyuria. And I'm looking at Robbie's face, but something he taught me, and I think it's really important, is that you're actually framing the problem correctly. Like no one comes in and says, hey, I have polyuria. They say, hey, I'm peeing more. And so you want to make sure it's not increased frequency without polyuria that may occur in UTI or urinary incontinence. So step 1, make sure it is polyuria, and you're going to do, close ins and outs. Then the specific gravity is going to be the most important component of this, because you really want to know, are you dealing with diabetes insipidus or diabetes mellitus? We talked about diabetes mellitus, hyperglycemia. The diabetes insipidus, the specific gravity is going to be low. It's going to be like 1.005. So the urine osms is going to be low for diabetes insipidus. We're not going to talk about how to distinguish central versus nephrogenic unless that becomes the case when we look at the specific gravity. So really, I think, and I'll give the word finding difficulty for Robbie to tackle. I'm just going to focus on the polyuria. Other things that can cause someone to pee a lot is hypercalcemia, but that's through nephrogenic diabetes insipidus. And quite frankly, I think I'm just checking a glucose. I'm getting a history of how much fluid this individual is drinking. And then I'm looking at that specific gravity as sort of my first steps in approaching polyuria.
Love that, Prof. Franz, anchoring us both in the pathophysiology, but also the very practical next steps. And I think a very practical analysis to the word finding difficulty is also probably in order. That means saying that essentially what you're trying to figure out is which one of the 2 speech disorders does this patient have at a broad level. And whenever you think speech, you think 2 things. You think, does this person have aphasia, or does this person have dysarthria? And again, taking a practical approach like Prof. Rez, at the internist level, you only really care and try to localize aphasia versus dysarthria in a very simplistic way. And the simplistic way is to try to turn the subtitles on. What do I mean by that? Like, imagine if a patient's talking to you, and as they say, they're describing the word finding difficulties, you are able to visualize the text that they are saying, and then distinguish aphasia and dysarthria from whether or not you're able to understand the text that they're saying. Dysarthria, it's flawless. You completely understand what they're saying because they're saying everything correctly, but they're pronouncing it in a way that is unusual, often not reflecting a pronunciation or a cultural difference, but reflecting pathology and anywhere along the motor tract that allows you to phonate correctly and proportionally correctly. If you're having word finding difficulties and you turn the subtitles on and the word finding difficulties are just as hard to understand, that's aphasia. And of course, people like Aaron can explain it with much more eloquence and simplicity. But that's honestly the most important thing to do right now. So that's probably what I'll be trying to do is first understand what is this word finding difficulty? Is it aphasia or dysarthria? I think when patients use the word finding, it often helps us start to lean more towards aphasia, given that aphasia involves searching for the words. Dysarthria has a problem pronouncing them, and the search or the finding aspect isn't often present for patients. So just the mere fact that the patient is using the word finding has me leaning more towards aphasia. And that's important because if we're dealing with acute aphasia, that has us worry about the possibility of vascular event. And so that's a reminder that not only do we have to localize what kind of speech difficulty this is, aphasia versus dysarthria, turn on subtitles, but we really have to understand the time course. Is this 1 week of slowly progressive aphasia? Or is this 1 week of aphasia that was abrupt in onset, but the patient decided not to seek care and it persisted? And so drawing the graph out of symptoms over time is going to be really, really important. I think one thing that you're going to see both me and Progress do right now is deliberately not try to link these things. They're too broad, each of them, and too many possibilities. And if you try to attach them and merge them together right now, you have one of two outcomes. You're either going to hit a home run, or you're going to completely fall flat over your face. And the odds of falling flat over your face are 99%, and in 1% you get lucky. So I highly recommend that since there are less than 100 people here, our chances of getting it correct from the get-go are very, very low. So keep these threads broad and avoid the step 1, step 2, and other test urge to link them together. In real life, it would be way too premature to do so. Sorry, Mark. Back to you.
All right, so some of the background data now, and a little more of the HPI. So essentially, like I mentioned, the patient has been endorsing polyuria, polydipsia, increased thirst for the last 2 weeks. And then 6 days prior to admission, he said he was extremely fatigued, but it was after like a long car drive, so he wasn't that concerned. And then 5 days prior to admission, his sister noticed that he seemed spacey and less interactive, and thought this was due to an emotional impact of he was actually at his husband's memorial. Unfortunately, his husband recently passed away, and his hands were also very having a lot of tremors, but this also improved. And then 3 days prior to admission, his sister spoke with him on the phone. He said his speech was normal, logical. And then 1 day prior to admission, he was with a friend who noted that his speech sounded nonsensical. He was having these word finding difficulties. So he referred him to the emergency room for further evaluation. So some of his background data, he has a history of HIV. This was diagnosed in the 1990s. His last CD4 that we can see in this system is 335. Really unclear if he's on antiretroviral therapy. He also has a history of COPD, Bell's palsy, hypertension, and pulmonary nodules. He's on albuterol, amlodipine, atorvastatin, benazepril, bupropion. The antiretroviral therapy that he was prescribed many years ago was emtricitabine, rilpivirine, and tenofovir. He's also on gabapentin. No known drug allergies. His father and paternal grandmother have lung cancer. And then kind of moving to the exam. So his vital signs, his blood pressure was 164/105. He was afebrile. His heart rate was 101. His respiratory rate was 16. And he was satting 98% on room air. I'll just to move through exam, I'll say his systemic exam was within normal limits in terms of HENT, cardiovascular, pulm, and GI. So I'll just kind of move to his neuro exam. So essentially for his mental status would fluctuate. He was alert and oriented to person. Place he knew was in the hospital, but didn't know which hospital he was in. And then when I asked him the year, he said it was 2050. But then other times he'd be a little more oriented to place. In terms of his attention, he was able to spell world backwards. And in terms of his language, he was fluent with intact repetition, naming, and comprehension. And then at worst, he would have decreased spontaneous speech and he would have some paraphasic errors. He could not name or repeat words as well, and couldn't follow one-step commands. His cranial nerves were intact besides a chronic right-sided Bell's palsy. Motor exam, he was 5 out of 5 throughout. Sensation to exam to light touch was intact. In terms of his coordination, his rapid alternating movements was normal. His heel to shin was normal. He had no dysmetria. And his gait was narrow-based. He had some disequilibrium, but he had a negative Romberg. And his reflexes were normal. And there were some times during the exam, and depending on who examined him as well, that he would have a right gaze preference, and then shortly after, he would have a lot of speech difficulty for like 1 to 2 minutes after. That's the end of this aliquot.
Wow, Mark, this is so intriguing, and thank you so much for such a rich neurological exam. I'm really excited to reflect on it, and maybe I can tackle everything else before that and leave that to mention for Prof. Rez. By the way, VJ, I'm really impressed with your scribing skills. I think keeping up with that neuro exam was really tough, so thank you for doing it. I think the really helpful thing about the HPI is to know how many eyes this patient has on him. It sounds like if he's doing the chestnut unfortunate society with lots of his lifetime partner, it seems that he's very well surrounded by people, and then being able to watch the camera is super helpful. And I think the most important thing that we learned about this speech issue, it was not abrupt in onset, that it's been slowly occurring for the last few days. Though we learn about a different twist of its onset on exam. And it goes to show you how the disconnect between the exam onset and the history onset is notable, and how we're always trying to constantly update our time course. And we know there's a subacute component to it based on exam, but then we hear that there's an acute on subacute component to it. We know that there's a subacute component on history, and then we hear that there's an additional twist of the time course, which is always so cool to never really lock in your time course until you have as much data as possible. I think the major reflection to have here is to reflect on how the diagnosis of HIV influences this case. And I don't know of a single clinical problem in which HIV does not influence the diagnostic landscape. And I think the teaching opportunity, Mark, that you're giving us is to talk about when we don't know if a patient's taking their medications, how do we make progress? And I think that you often look back and see what their CD4 count is and see what their viral load is. And you can start to predict if the worst case scenario, the patient's not taking their medications, what will happen. And the first thing that happens when a patient stops taking their medications is their viral load becomes unsuppressed. That is the most sensitive marker of adherence to appropriate antiretroviral therapy. Sometimes, even if you're taking your ART, you may have a resistant organism or malabsorption issues. So it's not always about taking it, but that tells you, is the patient getting treatment for the HIV or not? That's the first thing. And then slowly but surely, your CD4 count will drop. How quickly does it drop is a function of what's called the CD4 count nadir. That's the lowest CD4 count that the patient reached before they were started on treatment. And the lower your CD4 count is, the lower your CD4 nadir is, the faster your CD4 count will drop. So if your CD4 nadir is really, really high, that you were actually diagnosed very quickly, your CD4 count never really dropped, you can predict that when the patient stops taking their medications or develops resistance, that their drop count will be much slower than somebody with a CD4 count that's low. So if you are really, really interested in figuring out where the patient might be right now before the data comes back, you could look back at the lowest CD4 count and start to plot a line. And for this patient, we might have access to prior CD4 counts. So what I would do in real time, if I didn't know he was taking his meds, I would open up all the CD4 counts that he has. And Mark, you don't need to do this. We'll wing with whatever data you have. But if I see a CD4 count, the lowest one I see is 200, then I'm very reassured, and I would doubt that this patient is correct below that in this period. I learned from my former program director, Harry Hollander, that on average, we can expect patients to drop 60 to 70 CD4 cells per year as a gestalt, but of course the nadir is a much more accurate place. So I think framing this problem is going to be really, really key. Is this a patient with HIV-related immunocompromise who's developing this syndrome? That even in the absence of immunocompromise, there are many HIV-related complications that are independent of the CD4 count. So we're going to have to entertain all of those. But I wouldn't be speculating on what those things are without understanding the syndrome better. And so I think for now, the HIV is noted. it's going to influence the landscape even if the CD4 count is normal. It's going to influence even more if the CD4 count is low. But I think the prudent thing to do is to start to really understand the current clinical syndrome. And so I'll pass the mic to Professor for any other thoughts he has. And yeah.
It always brings me joy when you say the words Harry Hollander. What an epic individual and what a role model for you and me, Robbie. I think really the problem we're solving is altered mental status, but it's a specific type of altered mental status, meaning that there might be some localization as to what's happening, but I'll be authentic with you all. How often do we have altered mental status with another finding like polyuria that is really pointing us towards a metabolic disturbance? Meaning that for me, getting to the bottom of the metabolic disturbance is likely going to get to the bottom of the altered mental status. The only reason I pause is because of the specific type of altered mental status. Mark is telling us this individual is comprehending okay, but is expressing themselves poorly, is having this right gaze preference. So all of that makes you wonder, is it more than just a metabolic disturbance that's causing abnormal activity in the brain? And is there a focal lesion, or do you have both? But I just wanted to really highlight that point that when you have polyuria, there's probably going to be a metabolic abnormality that we're going to encounter, whether it's a urinalysis, whether it's a BMP, and you have to continue tracking that problem because that's an important one if it in fact is real. Now, we talked about mimics of polyuria. If you told me someone has urinary incontinence, confabulation, a narrow-based gait, I would think of normal pressure hydrocephalus. And so you have to keep that DDX broad. I'm not sure on day one, it's almost impossible to confirm polyuria. You'll be tracking the ins and outs, but you'll be looking for that glucose. You'll be looking for the patient's, any kind of electrolyte abnormality. But if you ask the question, like, where is our language center? And it seems, Robbie, in this patient, it's more than a hardware issue. It's more than he doesn't have dentures. He doesn't have Invisalign. He doesn't have something obstructing his ability to speak. So then you ask the question, and it's so nice, like the auditory cortex, the neurons land literally where the receptive pathway is for understanding language, to comprehend the what pathway, which is connected to the what you want to say pathway, the expressive pathway. And all that then connects to the premotor cortex that allows you to do what I'm doing right now in speaking. So Mark, really, I'm worried about this guy's expressive area. And I think what I would do next is get a CAT scan because it's going to be quick. He may ultimately need an MRI. I will also look for any obvious, like if his calcium is very high or glucose is very high, maybe this is all hyperglycemia related. So I think a CAT scan, the CBC, the BMP, the urinalysis, and then pending those results, we'll see what else, we find. And I think like the idea of, could this be a seizure? It could always be a seizure, but I'm not there yet to pull the trigger on an EEG. I think we first have to look for structural abnormality and metabolic disturbance. Maybe, Robbie, is this an okay time for us to pause? Or do you want him to share the next aliquot and then we pause?
We have 3 minutes, right? Or, yeah, let's get the next round of data and then we'll all just go in a break room. Good? All right, Mark. Thank you.
Awesome. So let's move on to some basic labs. So going to the first I'll give the point of care glucose. So the point of care glucose was 550. The A1C was 14. The last A1C a few months ago was 6. The creatinine was 0.98. BUN is 22. Sodium of 129. Potassium of 4.1. Chloride of 92. Bicarb of 22. Calcium of 9.2. Albumin of 3.2. Total protein of 7.4. Total bilirubin of 1.2. alk phos of 353, ALT of 34, AST of 39, an anion gap of 15. And for the CBC, his white count was 15.2 with neutrophilia. His hemoglobin was 15.5, MCV of 90. His platelets were 336. His coags were within normal limits. He had a beta hydroxybutyrate, which was 3.59. The UA as requested had a specific gravity of 1020, a lot of glucose, and 40 ketones. He had a urine drug screen, which was just positive for THC. And then he had a CT head, which was within normal limits. Any other basic labs that you guys want?
I know that some people probably totally go there regarding probably on their phone. So maybe I can just take a moment to summarize the key data and then we can go into the breakout room. Is that okay? So I see the patient has a neutrophilic leukocytosis, has a sodium that is corrected okay for the glucose, has an isolated elevation of phosphatide, other hepatocellular groups, and has a moderately elevated beta hydroxybutyrate and a high specific gravity. Anything else catch your eye, Prof. Rez? Mark, anything that we missed?
And the A1C of 14, and then
That's right. I'm so sorry.
Yeah, no. And the previous A1C, like I think it was like 4 months ago, was 6.
I missed the single most important data. I would argue I missed it. Thank you for catching that. All right, y'all. We'll see you all in 6 to 7 minutes. Okay? Enjoy the nerding out. I think you're up, Prof. Rez.
Okay, excellent. Welcome back, everyone. But something interesting that Jokic did say, we're having a little side chat, and Robbie's like angry that I'm taking it back to Jokic.
No, not at all.
When he won his 3rd MVP award, he's like, I don't know why people cry over this award. Like, it's fine, like it's okay, but it means not, like it really doesn't mean anything to him. Then they said, I don't know if he actually said this or if this is just fake news. He's like, I'll just give it to my horses and they'll play with the award.
Oh my God. It's literally like,
I don't know if that's true. But, anyways, very excited to discuss this, both because I think you have created so many figures for diabetes, and we got Tiago, our superb endocrinologist, who happens to always be there when there's a hyperglycemia in the background. So I'm really interested. Maybe Robbie, I'll start with just talking about the sugars and like how I would like authentically approach that, both management wise and from a treatment perspective. But then I would love for you to keep following that thread of the confusion and like whether that matches up with the glucose or whether we have to do more investigation there. I think now we have the answer to one of the problems of this case. Like Mark told us, and I don't see Mark anymore, but I'm sure he's on. Mark told us that the main issue was polyuria, and applying base rate, we said, make sure it's not a mimic like a UTI, urinary incontinence. Make sure they're not on diuretic therapy, but glucose is going to be your best friend. And that's probably usually going to be the answer there. So now we have the answer to the polyuria, which means we also have the answer to the polydipsia, because if you're losing a lot of volume, and I think this really highlights how patients with hyperglycemia are quite volume deficient. They're quite volume deficient. And when you're that hypovolemic, you're going to have a very strong stimulus to drink fluid. And so now we've answered the polyuria, the polydipsia, but what we haven't answered is the hyperglycemia. And the hyperglycemia is really interesting because Mark shared with us just a couple months ago, the A1C was normal. And now the A1C has more than doubled, And if you were going to ask the question, who comes to clinical attention quicker? Those with hyperosmolar hyperglycemic state or those with DKA and hyperglycemia? It's the DKA folks. And why is that? Because they usually develop abdominal pain, which wasn't part of this clinical syndrome for this individual, but DKA is more sudden in onset. it's more symptomatic initially, and the patient presents to clinical attention quicker. While the hyperosmolar hyperglycemia tends to develop over time until the glucose is so high, and then all of a sudden you have literally swelling of the brain cells and an effect on the neurologic status of the individual. But I've gone away from thinking of these two clinical entities as distinct and really thinking of them as having an overlap, because there are patients who have type 2 diabetes who become so hyperglycemic that they get glucose toxicity to the pancreas, and now they have a stunned pancreas that loses its endocrine function and doesn't release insulin. So then they develop ketosis. So they have ketosis and HHS simultaneously. I just want to talk a little bit about the, and I have to be careful I don't speak too much here because we've thought so much about diabetes. But when you're looking at someone's sodium, you always have to ask, what is the glucose? And Rabih did that reflexively, but for some of you, it might not be reflexive. So you see that sodium of 129, you look at the glucose is 550. It's about 400 above the normal levels. For every 100 above, you're looking between 1 and 2 rise in the sodium. So 4, let's say times 2 is 8. Let's say between 6 and 8. So this guy's sodium is totally normal. The sodium is totally normal. But then the question becomes, what about the anion gap? What should you use? Should you use the sodium that's measured, or should you use the corrected? There's a video from a couple of years ago that we addressed this issue, but I will say this. You just use the measured sodium. And the reason you use the measured sodium is because you're using the measured bicarb. The only reason we correct the sodium for the glucose is because when the glucose is this high and you no longer have insulin, glucose becomes a tonic particle. It's not just an osmol, it's a tonic, meaning it's not going into the cell. So it's drawing fluid out of the cell and it's doing the function of sodium. So from a management lens, I know that this patient is going to need fluids. The fluids they need is not as much as HHS, but they'll still need a ton of fluid. They really will. They'll need a ton of fluid, and that creatinine is probably an overestimate for the degree of renal insufficiency. I bet their muscle mass isn't there or something, because I would expect a higher creatinine. Then the other thing is, in order to go into ketosis, you really have to be insulin deficient. I would almost say like lack of all insulin, because insulin is such a strong inhibitor of ketosis. Because when there's insulin on board, it means there's glucose on board. And if you had to choose between an efficient molecule and an inefficient molecule for energy, you choose the efficient molecule. So you're going to shut down the inefficient molecule. And by the way, we all have ketosis when we go to, unless you're snacking very late at night, you're going to develop some degree of ketosis, but you're just going to pee out those ketones. Your bicarb is never going to drop too low. So now that we have ketosis, we have to look at this patient's bicarb, and this bicarb is 22. That bicarb is, interestingly, with ketosis, you can get very, very low bicarbs when you're insulinopenic. So I would get a VBG in this patient just to see if we have an additional alkalosis on board. I would get a VBG, but this patient needs insulin. This patient needs insulin to shut off the ketosis. You just have to be cautious here because you have to just monitor what's happening to the glucose. And most importantly, you have to be monitoring what's happening to the potassium. Imagine you give someone insulin and the potassium is low, and all of a sudden they become severely hypokalemic. So from a management lens, it's really fluids, insulin, potassium, and I would look at the magnesium and the phosphate as well. I would put this person on an insulin drip with this degree of ketosis, though you can say, what about the bicarb? I don't know what to make of that. I really would want a VBG. But then the question becomes, why are they in an insulin deficient state? This is someone with a normal A1C just months prior. I would actually prioritize insulinopenia over insulin resistance. That's really how we categorize diabetes, right? Insulin resistance is like someone's gaining a lot of weight, the cells are growing, they're not as sensitive to insulin. And eventually those patients that have obesity, the metabolic syndrome, their pancreas will fail. Like it would lose its capacity to release insulin because it has to go into overdrive. That's not this patient. This patient is having insulin deficiency. So then the question becomes, what can cause insulin deficiency? And here you can think of it in multiple ways. One way is that someone has a pancreatic cancer, for example. And I've seen this actually before, where over a couple of months, the A1C just jumps significantly, and they really lose that endocrine function of that pancreas. The other ways you can think of this is medications. You really have to review the patient's meds. We've seen this with olanzapine that can cause both resistance and affect the pancreatic function. So you really want to review the medication list to see, is there anything that can be toxic to that native pancreas to cause that to go into an insulinopenic state. Then there's less common etiologies like hemochromatosis, cystic fibrosis. But before you even think about toxins, before you even think about pancreatic cancer, know that you can have, and I don't know which term Tiago doesn't like, and I don't want to mess this up, but know that as you age, you can get antibodies and destroy your pancreas. So you can get type 1 diabetes in adult age. And I'm not going to use the term LADA because he doesn't like that. Am I right? Give me a nod there. But anyways, I'm actually gonna pause there, Robbie. I want you to just layer onto that because I know you've thought about this so often. But I just think the problem we're solving here is treat the ketosis, treat the volume deficit, watch the potassium, image the pancreas, but look for medications that can be toxic to the pancreas, and then just ask the question, is this late onset type 1 diabetes? And then say, could this actually explain what's happening in the mental status and the aphasia?
Yeah, I love it, Professor. I think that I don't have anything to layer onto the diabetes conversation because you covered it all. But I think that the key question is, do we have two leads to chase in this patient or just one? And if we were just to take a moment to summarize what we have a 61-year-old woman who has HIV without clear status of his immune system. He's coming in with two things. He's coming with altered mental status and polydipsia. The altered mental status, we've now clarified that it comes with aphasia, and that aphasia seems to be intermittent, associated with right-sided gaze preference. The polydipsia and polyuria is now classified as a new diagnosis of diabetes, along with an overlap of UK HHS. And we've heard how Prof. is thinking about that and how Prof. is advancing that. And I think the parallel question to think about is, what should we think about the fact that he's having transient right-sided gaze preference and an inclusion? Especially in a patient with HIV, you might be inclined to push this further and further and further, well beyond the CT, to include MRI with and without contrast, and to include a lumbar puncture. I understand that temptation, but it's not a temptation that I would be doing. What I would be focused on is the very intimate association with HHS and seizure activity. In fact, the term diabetic stereotopathy is a specific condition so common that it now has a name that outlines how patients can get focal neurological deficits in their hyperosmotic phases. And I think that that is a very plausible and very compatible diagnosis with what the patient has. So in real life, I would avoid the temptation to expend a lot of diagnostic energy, time, and effort and resources in chasing down this patient's neurological. There's a very, very compelling reason to stop and focus on the glucose for two reasons. The first is that the CT scan is not showing any devastating crisis and requires you at least a day. The second is that patients with diabetic stereotopathy who have HHS and seizure-like manifestations often improve pretty quickly with glucose control. So when you merge those two facts together, that there's no intrinsic neurological injury, and that you have the ability to actually test this hypothesis of diabetic stereotopathy by focusing on the management principles outlined by Prof. Rez, you'll know pretty quickly whether you need to stay in this lane or pivot back towards HIV and other complications on day 2 and day 3. So I think that this problem really comes down to Prof. Rez, the analysis of the sugar that you have. I think the other dimensions are likely to be a consequence of the hypoglycemia, not a separate unrelated one. So that's how I would be incorporating the other aspect, is to literally diagnostically ignore it. All right, Mark, I can't wait to eat my words at the end of this by telling us to ignore the mental status. But here's to hoping. I'll give the mic to you for the next talk.
Yeah, no. So one thing to add too is that, the emergency room did a great job at controlling the like mild DKA, got him on high doses of insulin because per our protocol, he met like our subcutaneous insulin pathway. So he was on high doses of subcutaneous insulin, and his sugars got down pretty quickly, but mental status was still the same. And you guys have taught me a lot about like the laws of proportionality, and I actually brought this up with my intern overlay. I'm like, I see a lot of hyperglycemia, but this mental say something seems a little off. I was like, something's not right here, especially in someone that, at least to my knowledge, doesn't have a susceptible brain. So then we put the patient on LTM, on continuous EEG, and he was having many, many seizures. So some of them he was having like the right gaze preference, but some of them he was just having the word final difficulties. So he was having many focal seizures, about like 5 per hour. So he was loaded with levetiracetam, still having seizures, was loaded with lacosamide as well. And then the seizure activity improved a little bit. So we also have an MRI, and I'll share the results of the MRI. So the MRI showed scattered punctate acute versus early subacute infarcts involving the bilaterum centrum semiovale, the left occipital lobe, and temporo-occipital junction, potentially thromboembolic. Most of these do not enhance, but there are scattered other enhancing foci as well with similar pattern of the different distribution. No convincing hemorrhagic transformation or significant mass effect. And yeah, those are the main findings on the MRI. We also, the following day, got a transthoracic echocardiogram that showed a normal EF and no embolic sources in the heart. This is the last aliquot before I reveal the data point that shows the final diagnosis. Any other things that you guys would like or I miss in terms of like basic advanced labs?
Super, super helpful and a dose of humble pie for me. I'll just share my reflection in a second. I'm curious if the unfortunately were unilateral or bilateral. Do you have findings across the hemispheres, or were they all on one side?
Yeah, bilateral.
I see that. Awesome. It's super, super helpful. Yeah, I think that like essentially the lack of I had no idea that you would be able to turn around and glucose so quickly and so effectively, and let alone being done by the brain serum. And that just goes to show you how much learning there is for us in the world of management reasoning, because I think I would have probably been much slower to come to the conclusion that hyperglycemia is not causing the symptoms, because it probably would have taken much longer to be able to cure this patient who would be HS. So kudos to you guys and your team for being able to spot that this case was going to spiral in a different direction. And I think now we really have to analyze both the hyperglycemia and the pathway that progress outlined, and then also the fact that this patient seems to have multifocal infarcts. And I will just say, like, I'll summarize, I'll just kind of paint a big picture view of how my mind analyzes the fact that the patient has multifocal infarcts, and then pass the mic to Rez. But just to say that I think it's a reminder that the most common cause of seizures in the older adult are strokes. And this is the likely connection that I would be pivoting between the EEG findings of the adult, is that a stroke is causing a seizure. And so the question is really all about, from a neurological perspective, what is the MRI? And the MRI is showing multifocal infarcts. And whenever you have multifocal infarcts, it really is a question of whether the patient has a really hypercoagulable condition that's causing clots to happen everywhere in all of those vessels. That is a very, very scary possibility. A very common and often simple alternate explanation is not that the patient has a devastating condition that causes them to clot off in the but the patient has a thrombogenic condition in one specific very bad location. And that location flicks off embolic discontention. So my mind is asking, does this person have a really bad condition, like APLS, or do they have a strategic vulnerability in a bad location causing thromboembolic disease? With the brain, it's very tempting to think that the only bad location is in the heart. That's not true. In addition to cardioembolism, we can get paradoxical embolism from PFOs in the vein. And in addition to vascular embolism, you can actually get obliteration of the arteries and veins as a result of meningitis and the effects of meninges on those vessels compressing. As a result of the irritated meninges compressing the vessels from which they exit. So remember that embolism to the brain involves thinking about the heart most commonly, thinking about DVTs, and also thinking about meninges and what's called obliterative vasculitis, or vasculitis that results from irritation by the meninges. That's the embolism hypothesis, and in parallel, we have to think about infective condition. But that's the very big picture view. I'm curious, Perez, where is your mind with all this information?
It's so interesting, Robbie. Oh, yeah, dude. Oh, it's so interesting in that, yeah, very good discussion. And it's like hard I don't know if we had to tell Alpha to make that microphone a little better because it's not your words are not coming out crisply, but maybe it's just for me, but that's okay. But I understand your general gist. I'm actually going to give my 2-minute time to Tiago to just share whatever thoughts he has. And I appreciate you, Mark, for saying that sub-Q looks totally fine here. You're right. The bicarb wasn't too low. It seems like fluid and sub-Q insulin would have worked perfectly. But for my 2 minutes, I'm going to give it to Tiago, and then Tiago can pass the mic back to you, Mark.
Hey, everyone. So good to be here. So cool. I don't know why I was able to come here, and this is an interesting case. Anyways, when I see this type of diabetes develop in the elderly with a lot of insulin deficiency, the first thing that I think is type 1. And then the second thing is pancreatic cancer. One thing that may happen is type 2 diabetes. With time, they have a lot of glucotoxicity. So if they have undiagnosed type 2, which is not the case here, you may present this way, even with HHS. And then they are fine with metformin only after, I don't know, 5-6 months. I have several cases that I've seen this way. But for this guy, for sure, type 1 and pancreatic cancer, and then all the zebras. There is a good New England Journal of Medicine case recently. They described a lot of zebras and a lot of razor resistance, but that's in my mind. Back to you.
What I love about that so much is I spoke for like 30 minutes to try to get those 2 sentences out. Thank you so much, Tiago. That was brilliant. Mike, to you, Mark.
Yeah, such a great discussion. Another piece of data point that we gained too, when we were able to get, the patient was kind of going in and out of like agitation and seizures, but we kind of got to talk to him a little more, and then mainly his sister, and he was having some weight loss over the last couple of months as well. So with all these findings, we decided to do a pan scan. This kind of happened a couple of days later because again, he was having, a lot of seizures and agitation. So it was tough to coordinate scans. So the results, the CT chest just showed his stable pulmonary nodules. And then his CT abdomen pelvis showed an ill-defined hypodense lesion in the tail of the pancreas, suspicion for metastatic pancreatic cancer, involvement in the splenic artery, and potentially local invasion of the adjacent spleen. There's also a right liver portal vein met, causing right portal vein occlusion, necrosis of the downstream liver parenchyma, possible invasion to the right lateral abdominal sidewall, and then also a portal vein thrombus extending into the left portal vein, likely tumor thrombus, and then some intrahepatic biliary ductal dilation. He got a IR-guided liver biopsy or pancreatic biopsy a few days later that confirmed metastatic pancreatic cancer.
This is extremely sad, of course. But Mark, I want to thank you for bringing this case to VMR because just like think about how great this case is. Like you start with polyuria. Why are they having polyuria? You have these word finding difficulties. Why are they having word finding difficulties? For the polyuria, you get to hyperglycemia, but why are they hyperglycemic? For the word finding difficulties, you get to seizure, but why are they having seizure? Then you get to bilateral infarcts, but why are they having bilateral infarcts? And then ultimately, using the law of proportionality, not dismissing the hyperglycemia for the word finding difficulties, and not just saying, oh, it's hyperglycemia, I'm going to treat it and discharge, you get to the answer. You know, you could easily like see if someone doesn't ask the question why. Now, let's say his word finding difficulties had resolved, right? Like he was no longer seizing. I could see so many people just discharging this patient and not doing that additional step. So I love that. And then Robbie, something that LT taught me, he said these patients with pancreatic cancer that, and he said this specifically in the context of the A1C shifting rapidly, they might have this metallic taste in their mouth. And I'm not saying that anyone with a metallic taste should get a pancreatic CT scan, but it's something that has stuck with me and it actually like proved to be true for one of my patients in the past decade. Anyways, Mark, I just want to thank you. And now I'll give the mic to Robbie to share his reflections. But from like a clinical reasoning perspective, I think this case like touches so many like interesting aspects.
I know, Mark, I really love this case. Just to show us that something that we deal with, so which is glucose control, glucose control, we have very morbid underlying diagnoses. If you ask yourself how many times the patient with diabetes do you like just go through the routine like increasing and focus on management? I think when patients with diabetes, a fraction of them profound. Now you've got two of them to VMR. What brought us a patient who had hereditary hemochromatosis, who had hypocalcemia and diabetes, and today is another really devastating diagnosis. So I'm really curious what your reflections is like. What is it like to actually navigate those things, and like, what lessons you learned from that we didn't share today?
Yeah, no, there's this, push in, the VMR community to just bring more bread and butter cases. So that's like one thing I really wanted to focus on, kind of like an atypical presentation of a common disease. I mean, we all love solving zebras. I feel like people in my residency program always make fun of me because I always want to, catch a zebra diagnosis. But I just really wanted to bring this case because these are the things that we're going to see commonly, like metastatic pancreatic cancer, unfortunately. But honestly, all of the focus overnight, and me and my wonderful intern Danny was before, and the MRI wasn't back until the following day, is like I thought this was a great case for HSV encephalitis, because we had the LTM and patient with HIV having new onset seizures and behavioral changes or some sort of encephalitis. I thought it fit pretty decent for encephalitis syndrome. And again, that's me having the LTM. And I think it's always interesting to see people analyze data kind of backwards, like how we, in real life, we have the data first and then we analyze the history, and you guys did such a nice job of just like getting analyzing the history without the data. But yeah, it's really hard for me too to think about secondary cause of diabetes. We just see it so commonly, and I think I'm always like, yeah, type 2 or type 1. But I think after we sat down and kind of went through the admission, me and Danny were just like, something just doesn't make sense. Like an A1C to 6 to 14, like this is just. I know type 2 diabetes is so common, but this is just such an atypical presentation. So, as the days went on, we kind of pushed to get the pan scan, and then we found this, devastating diagnosis. But yeah, no, really, I mean, it's, metastatic pancreatic cancer presenting as like symptomatic hyperglycemia with seizures and strokes. It's just, medicine is just incredibly humbling. So, yeah.
We're always so grateful for you, Mark. I think that you practice learning for us in such a digestible way, and realize that there's a lot of 99% of this is bread and butter, and I really appreciate you giving us stuff. And we got a lot of pathophysiology from Rafael, and we got the endocrine guru, Endo Dialogues, to dialogue with us today. So thank you, all of you. And last but not least, take it away.
Well, thank you so much, Mark, again, for bringing us this case. And thank you also to Ravi and Prof. Rez, who are always teaching us a lot. I want to keep this, and I'll try to keep these very, very brief. We started this case with polyuria, which is defined as having more than 3 liters of urine a day. And Prof. Rez shared this amazing pearl of, first of all, making sure it's actually polyuria, and then try to identify what presented first, because usually polyuria is going to prompt polydipsia when we have patients with both symptoms. Then it's going to be really useful to assess the glucose through urinalysis. We can check, obviously, the glucose there and then the specific gravity, because it's going to be useful to differentiate from diabetes insipidus and regular diabetes. Another cause of polyuria is hypercalcemia, so don't forget to check the calcium. And also think about the mimics of polyuria, like urinary incontinence and confabulation. Then we moved forward with speech problems, and Rabih made us the great difference between aphasia and dysarthria. Remember that aphasia is going to be a problem finding words, whether dysarthria is going to be a problem pronunciating those words. So as he said, try to put the subtitles on a patient to identify which is the problem that you're dealing with. And also try to understand the time course, because it's usually very, very important in neurological conditions. And then that can make us evaluate a little bit further if it's a structural lesion versus a metabolic abnormality. We also talked about HIV diagnosis pearls, and we got that the most sensitive marker for bad treatment adherence is the viral load. It's going to be elevated first. Not the CD count, that it's going to be low. And also think about the HIV-related complications that are not necessarily related to the CD count. Moving forward with the hyperglycemia, we learned and we will remember that patients who have a hyperglycemia are always going to be hypovolemic, so they're always going to need fluids. Usually when we're thinking about hyperglycemia, we're thinking about DKA and HHS. DKA is usually a little bit more sudden and more symptomatic, whether HHS, it's a little bit more slowly to progress. And the treatment, it's going to be fluids, check potassium, and give insulin. And we also need to be well aware of correcting the sodium according to the glucose levels, and also check for acid-base blood disturbances. And then lastly, when we talk about thrombotic events, we need to remember that when we have multiple infarcts in the brain, the heart, it's not all the time the source. We can have paradoxical embolisms and problems in the meninges like vasculitis. So that should also be interdifferential. And lastly, I want to end the teaching points with something that Dr. Tiago said, that was when you have an older person that has an insulin deficiency and a late onset of diabetes, we should think about type 1 diabetes, pancreatic cancer, or long-standing type 2 diabetes with glucotoxicity. And after we have ruled that out, we can start thinking about the CRES.
You see Prof. Rez's screen? I mean, Prof. Rez got to do it again. I think that summarizes what this happened. Woo! Launched us right into orbit. I mean, that was amazing. I think it's always a wise idea to end with Tiago wisdom. I especially love how you bulleted each section of the teaching and divided it that way. It's so much easier to remember it with the broad categories. So thank you so much. All right, y'all have a great rest of your Friday. See you next time.
Safe flight, Robbie.